she's the core member of the White Army, and she's moderating the sessions, ma'am.
Third year MBBS, sir?
Yes, madam.
Okay.
Can we begin, ma'am?
Yeah.
Yes, ma'am. Coming to the, I'll be presenting a case of Mrs. XYZ, who's a 50-year-old female, housemaker by occupation, residing from Kolar, belonging to the lower middle class of BG Prasad classification, who came with the chief complaints of breathlessness in 6 months, palpitations since 3 months, and bilateral swelling of lower limb since 1 week. Patient was apparently...
I think you can mute others.
Yes, ma'am.
Lot of background. I will also...
Balaji, please continue. Yeah, mute.
Yes. So patient was apparently asymptomatic, was performing her daily activity 6 months ago. When she initially started noticing breathlessness while climbing 3 flights of stairs, which she was previously able to climb, all this started since 6 months, which was insidious in onset, gradually progressive. They increased on exertion and the breathlessness reduced on taking rest and on sleeping. The symptoms gradually progressed such that 2 months later, the patient had frequent episodes of feeling breathlessness during sleep, which began 2 hours after sleep and was relieved after sitting in the bed and taking deep breaths for about 15 to 20 minutes. Once the patient developed these symptoms, patient was taken to a local hospital 2 months ago and was told to have a heart disease which may require surgery, and was also given oral medications, following which the patient had symptomatic relief and was able to perform her routine daily activities with improvement in the breathlessness and the sleep. Currently, the breathlessness has progressed such that the patient feels breathless even on sitting in the bed and on performing activities like combing the hair or wearing the dress, and it worsens immediately after lying supine with no relief on consumption of even oral medications. So after the breathlessness, patient also started developing palpitations since 3 months. The palpitations were insidious in onset, progressive in nature such that the patient experienced palpitations initially only on exertion. They lasted for about 5 to 7 minutes, which was regular in nature. They relieved on taking rest or oral medications, and patient currently feels the palpitations are regular during rest, and occasionally they disturb the sleep since the past 3 weeks. The patient also developed painless swelling of bilateral lower limb since 1 week, such that patient noticed the swelling up till the mid calf, which reduced partially on limb elevation and oral medications. There is no history of chest pain, post-palpitational diuresis. Ma'am?
Shall we stop here and then?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So starting with the first symptom, can you go to the first slide?
Yes, ma'am.
Yeah. So the first and the most important symptom appears to be breathlessness.
Yes, ma'am.
So others can answer, or only you have to answer?
Others will answer in the chat section, madam, usually.
Okay, okay. So
is that okay, madam?
Yeah, whatever is convenient. Okay. What is the definition of dyspnea, Vijay? Hello?
Hello, yes, ma'am.
Yeah, you usually start with dyspnea definition, right?
Yes, ma'am.
Can you tell?
Dyspnea is unpleasant awareness of one's own breathing, ma'am.
Can you mention some causes of dyspnea?
Dyspnea can be secondary to a respiratory cause, a cardiac cause. Cardiac cause, commonly we can have...
Beyond that, see, many times
yes,
they come, they will not have any cardiac problem. Can you mention other causes also?
Yes, ma'am. Cardiac causes can be
No. Cardiac, respiratory, any other causes. These are the two important causes.
Cardiac,
but also
respiratory.
keep in mind other causes.
Yes,
Like
one more can be hyperventilation, which is psychogenic.
yeah. Then
anxiety.
Then anemia.
Anemia, yes, ma'am.
Yeah, see,
anemia,
always
thyroid disease. Yes, ma'am.
Yeah, anemia is always so common in our country. You should keep in mind, even with the Valvular heart disease, they may become symptomatic because of anemia. So you should always keep that in mind.
Yes.
Then, any other thing comes to your mind? Obesity.
Obesity, yes, ma'am.
Physical deconditioning. If somebody is in bed for 3 weeks, they start walking or climbing one flight of stairs, they may become dyspneic. So these are some things you should keep in mind when you don't have obvious respiratory or cardiac causes for dyspnea. You should think of other causes.
Yes,
Coming back to the two most common causes, when do you think it's cardiac? What makes you think of respiratory origin of dyspnea?
Yes, ma'am. So whenever there is a cough preceding the breathlessness, we usually think of a respiratory cause, ma'am.
It's not just one. See, cough. Can you not get cough in cardiac patients?
We can get, ma'am. Yes, we can get. Yes, ma'am.
Anything else? Yeah.
Yes, ma'am. Cough with very minimal expectoration usually in cardiac cause, whereas cough with expectoration, with moderate expectoration.
Okay, fine. Then
following that, the patient develops breathlessness in a respiratory cause. There may be
history of wheezing, seasonal variations, long history. You know it.
Yes, ma'am.
All those conditions favor
a respiratory cause.
Respiratory cause, whereas
breathlessness, breathlessness preceding the cough, and the history of PND and orthopnea favor more of a cardiac cause than a respiratory cause.
Correct, very good. And also other symptoms of cardiac disease, like maybe palpitation, chest pain, syncope. If those symptoms are there, then it favors cardiac cause. Yes, so once you decide that it is cardiac, what are the mechanisms of dyspnea in a patient with cardiac disease?
Yes, ma'am. So usually breathlessness occurs because of imminent LV dysfunction, so LV failure, ma'am.
Can you use a better word?
Left ventricular.
In mitral, what is the most common valvular lesion which causes dyspnea?
Mitral stenosis causes.
Correct. Dyspnea. So what happens? The earliest symptom in mitral stenosis.
Pulmonary venous hypertension is the initial cause.
In mitral stenosis, the first thing to happen is elevation in the left atrial pressure, which is passively transmitted in the pulmonary veins.
Yes, ma'am.
So when there is pulmonary venous hypertension, dyspnea is an early symptom. So why do they get dyspnea due to pulmonary venous hypertension? Why should they get? When the pulmonary venous pressure increases, what are the mechanisms which cause?
So whenever there's a pulmonary venous hypertension, the normal interstitium is able to drive off fluid, ma'am. So because the congestion occurs, because of pulmonary venous hypertension, there is interstitial edema and interstitial edema. This interstitial edema is going to stimulate the juxtapulmonary receptors is one, ma'am. And
correct.
Because of this,
the most talked about is stimulation of the J receptor. Where are these J receptors?
Just adjacent to the alveolo-capillary membrane, ma'am.
Yeah, they're between
the interstitium.
Yeah, they're between the alveolar epithelial cells and the endothelial cells of the capillaries. You know who described this?
Outer Singh Paintal, an Indian physiologist.
It is A.S. Paintal. A.S. Paintal is an Indian, that is why we are interested. So, stimulation of the J receptors, one. Second, because of increased fluid in the interstitium,
gas
there is
also
decreased lung compliance. Once the lung compliance is reduced, work of breathing increases. Right?
Yes, ma'am.
Okay, that is second thing. Third is there can be mucosal edema of the bronchi. So there can be airway resistance, increased airway resistance. Sometimes there may be even spasm. So they will have the reduced vital capacity. Lot of lung dynamics can occur in patient with mitral stenosis. So the lung capacity, lung compliance is reduced.
Yes, ma'am.
And in late stages, because of low cardiac output, there may be respiratory muscle fatigue due to low cardiac output. So all these can contribute to dyspnea in a patient with left-sided failure.
Yes, ma'am.
So what is the difference between dyspnea in MS versus other valvular lesions like MR, AS, AR? Can you think of?
Dyspnea in MS is mainly because of pulmonary hypertension and because of elevated left pulmonary capillary wedge pressure, ma'am.
See, in all these conditions, there is increased pulmonary venous pressure,
Pressure, yes, ma'am.
increased LA pressure. So what is the difference is in MS,
LV is
yes,
spared in mitral stenosis, whereas
yes. In MS, my LV is not failed. LV is normal. LV function
LV
is
is
normal.
normal. In MR and other conditions, the LV is the main.
Yeah, dyspnea occurs in MR or aortic valve disease when the LV dysfunction occurs.
Yes,
Whereas in MS, the moment the LA pressure starts going up, pulmonary venous hypertension occurs. So it's an early symptom. Whereas in MR, ASAR, it's a late symptom in the natural history because it starts when the LV dysfunction occurs. So that is why it is important to differentiate. Because in MS, they will have dyspnea for many years.
yes, yes, ma'am.
So when the LA pressure goes up, what makes the LA pressure go up? One is obstruction. Anything else can make the LA
You
pressure
can
go up?
have sudden arrhythmias that can develop that can cause the
Yeah,
LV.
any increase in heart rate,
Heart
any
rate.
increase in heart rate, it just doesn't double it. It 4 times increases gradient. So LA pressure increases. So increase the volume, like anemia, pregnancy, all these can increase the LA pressure. So once you treat, they can become normal. That is why they have a long history of worsening, improving, more than 5 years, 10 years history. So whereas in MR, AS or AR, aortic valve disease, once they develop dyspnea, it's a downhill course. Because most often dyspnea is here because of LV dysfunction. Okay. So any other mechanism for dyspnea, even in right-sided disease, shunt lesions, cyanotic heart disease, you can get dyspnea. Can you tell any other mechanisms? The most important mechanism is pulmonary venous hypertension, which can be because of valvular disease or LV dysfunction, as you said, like in coronary artery disease, dilated cardiomyopathy, hypertensive heart disease with very diastolic dysfunction. So all these finally cause increase in LA pressure as well as pulmonary venous pressure.
Yes.
But sometimes you get dyspnea because of other causes, right-sided diseases, acute pulmonary embolism, shunt lesions. Can you tell any other mechanism for dyspnea?
VQ mismatch can occur whenever
Correct.
there is a
Yes.
shunt lesion, so that can cause
Yeah.
hypoxemia and then that can worsen the dyspnea.
Okay. Even in TAF, just hypoxia can cause dyspnea. It's perceived as dyspnea. Then, as you said, ventilation perfusion mismatch in pulmonary embolism or any other conditions where there is ventilation perfusion. Then, any low cardiac output, as we already discussed, respiratory muscle fatigue. Okay. And in shunt lesions, it's basically because of
Pulmonary hypertension.
decreased lung compliance. No. Before they develop pulmonary hypertension, they can have dyspnea.
Yes.
Because of pulmonary arteries are dilated. There is no more blood in the lungs. Pulmonary veins are dilated. So the lung compliance is reduced. And work of breathing increases. Okay. So now, did you say the class of dyspnea here? Assessment of.
I didn't mention it here, ma'am. I mentioned it in the summary, ma'am.
Okay.
NYHA class.
No, I think in the history itself, you should start whether it started as class 2, class 3.
Initially, it started as class 2 and became class 3 when patient started developing PND. And then currently, patient is in class 4 NYHA.
Okay. So can you tell what is NYHA class 1, 2, 3, 4?
So NYHA classification is divided into.
There are some MBBS students, they know what is NYHA?
Yes, ma'am.
New York Heart Association classification. Can you mention what is
Yes,
1,
ma'am.
2, 3, 4?
1, 2, 3, and 4, ma'am. So we take two parameters. One is the physical activity, and what is the response to a physical activity. So there is no limitation of physical activity in class
See,
1.
when you're asked definitions are you have to reproduce as it is. You have to understand and memorize.
Yes, ma'am.
So you can't make your own sentences.
Yes,
You can tell what is
yes, ma'am.
class 1.
Class 1, there is no limitation of physical activity.
How do you start? Patient with this NVH classification is only for patient with heart disease.
Patient with dyspnea, fatigue, and
No. Patient with heart disease.
patient with the non-structural heart disease.
No, it's not even told non-structural heart disease. Just said patient
This
with heart disease.
Okay. Patient
No
with heart
limit.
disease with
Yes,
no
no
limitation
limitation of ordinary activity.
activity.
Ordinary physical activity does not cause undue fatigue.
Fatigue
What are
or
the
breathlessness.
fatigue, dyspnea? What are the other two symptoms? There are 4 symptoms.
Fatigue, palpitations, breathlessness,
And
chest pain.
chest pain. So you should start like that. Any NVHA class, if you are asked what is NVHA class 3, you should start with patient with heart disease. No limitation of ordinary
Physical
activity. Ordinary physical activity does not lead to
any
undue fatigue,
symptom.
dyspnea, chest pain, or palpitation. 1. What is 2?
2 is there is mild limitation of physical activity with the patient with symptoms developing on performing greater than normal, greater than ordinary physical activity.
No. Okay, patient with heart disease again. No,
Yes.
there is slight limitation of ordinary physical activity. Patient is asymptomatic at rest. Ordinary physical activity causes one of these symptoms or one or more of these symptoms. So class 3 is?
There is moderate limitation of physical activity and less than ordinary.
Unfortunately, there is no moderate. Again, patient with heart disease, marked limitation of ordinary physical activity. Patient is asymptomatic at rest. Less than ordinary activity
physical activity
leads
causes
to
symptoms.
these symptoms. See, these class 4 is?
Patient is with known heart disease and has there is patient is dyspneic at rest. And
patient will have dyspnea at rest. Cannot carry out any activity
routine
without
daily
symptoms.
Without
So
symptoms.
this is the most commonly used functional class, and you should
Yes, ma'am.
reproduce it as it is. Okay.
Yes, ma'am.
So what is the advantage of this NVHA class?
Advantages, it is dynamic, so it can be used to respond. One is we can, at the time of diagnosis, it can be used to stratify the severity of the condition, ma'am. And we can also know the response to the treatment, how the patient improves with based on the classification.
See, as you understand, it's a very simple one.
Simple.
Right? Very simple. Anybody can understand. So that is why it is most commonly used. But the problem, what are the shortcomings of this NVHA class?
Because there is a patient can have a heart disease which may be severe, but a functional class can be different based on the NYHA, ma'am.
So it is subjective. Somebody has put it. It's good. It's subjective. So it is different from a heavy manual laborer versus a sedentary worker. What you are defining is ordinary physical activity, which is different for different people. One. Second, many symptoms are not included. For that matter, syncope is not included. PND is not included, but we try to put it in class 3. Then what else? And between 2 and 3, reproducibility is
very
less, around 50-55%. So these are some shortcomings. Still, this is the most commonly used functional class in cardiology. All clinical trials, everywhere this is used. Do you know anything other than this NVHA class, functional class?
One is the Canadian cardiac CCS grading.
What is that?
Not sure of the parameters that is involved in that.
That is similar to this. One, it is used only for angina. Second, there is some objectivity, like they say beyond 2 blocks, 1 flight of stairs. So it's okay. You should know that it is used only for engine. Third, which is more objective. You're aware of anything?
Staging of heart failure, A, B, C, D.
No. Have you heard of Goldman's specific activity scale?
No.
Goldman specific activity scale. These are some of the things you can know. Goldman specific activity scale. There we use metabolic equivalents. I think there is mixture of students here. I don't know where I should stop. Anyway, this is important because it is objective.
Yes, ma'am.
Okay. You know what is 1 met?
No, ma'am.
Have you worked in treadmill?
Yes, ma'am.
Yeah. So there we use 1 met. To assess the functional capacity, you use MET. MET is a metabolic equivalent. It is oxygen consumption at rest by a 40-year-old,
Okay.
70 kg, but whatever it is 3.5 ml per kg per minute. Okay? 3.5 ml per kg per minute. So multiples of this is used to assess the functional capacity. Okay?
Yes, ma'am.
1 met is 3.5 ml. So this is very commonly used.
Okay.
So if you say 10 mets, that means 35 ml. Okay.
35.
So you don't have to calculate that. But normally, how much should you attain when you do a treadmill? How many mets you should attain? More than 10 mets.
More than 10.
Okay. So you heard of activity of daily living, no? Eating, tubing, bathing, resting. So how many mets it takes? Around 4 mets.
Yes, ma'am.
Okay, based on this functional class of Goldman specific activity scale, if a person can achieve more than 7 mets, it is class 1.
Okay.
Between 5 to 7 mets, it is class 2.
Okay.
Between 2 to 5 mets, it is class 3.
Yes,
and class 4 is same for all functional class. It is rest. Less than 2 mets. So you don't have to do treadmill, but you can know how many mets needed for each activity. Climbing 1 flight of stairs, carrying some weight, it takes around 7 mets. So like that, you can know the metabolic equivalents needed for each activity. And based on that, it's very important because when you are giving fitness for a non-cardiac surgery in a cardiac patient, if they can attain more than 7 mets,
they can,
or the history suggests you of functional capacity more than 7 mets, then they can undergo surgery without any
complication
problem. So that is important in assessing the functional capacity. So these 3 things you can know.
Yes,
but one more I would suggest is where syncope is included.
Yes, ma'am.
Do you know that?
No.
This is WHO classification, functional classification for patients with pulmonary hypertension. Because pre-syncope is included here, because pre-syncope is a common symptom in patients with pulmonary hypertension. It replaces palpitation in the NYHA class. Everything else is same.
Same, okay.
So instead of palpitation, you have pre-syncope in WHO classification for functional class for pulmonary hypertension. Okay, so we'll stop at that.
Yes, ma'am.
Functional class. So you should start. Anyway, you told in the symptom that it started gradually and now you think it's progressed to class 4. That you're going to tell it. Okay. Now, once you say dyspnea, what are the other things you want to ask? You said there is history of
PND and orthopnea.
PND. What is PND?
PND stands for paroxysmal nocturnal dyspnea, wherein the patient starts developing breathlessness about 2 to 5 hours after sleep.
Not 5 hours, 2 to 3
2
hours.
to 3 hours after sleep.
5 hours. Yeah.
2 to 3 hours after sleep, mainly occurring in the REM phase of sleep.
No, that and all we don't know. It is symptom, right?
Symptom.
It can occur
usually occurring 2 to 3 hours after sleep, such that it awakens the patient from sleep and patient has a air hunger, wherein patient takes deep breaths for about 20 to 15 to 30 minutes, following which the breathlessness reduces.
Yeah. This is a frightening symptom. Actually, patient goes to sleep after 2 to 3 hours, suddenly gets up with dyspnea, cough, maybe there is some frothy sputum, and about 15 minutes or 20 minutes, they will go to the window or dangling of the feet. So this reduces the symptoms. Yeah. So before that, which comes first in the natural history, PND or orthopnea?
Initially PND, followed by that orthopnea.
Correct.
Both
PND
usually
comes around class 2 to 3, around, so it's in the 3. So
Yes.
then what is orthopnea? We'll come to the mechanisms later because
Yes, ma'am.
this
Orthopnea.
patient has orthopnea.
Yes, ma'am. Patient has orthopnea, and patient feels breathless immediately after lying down.
Supine position.
Yes,
Okay. Can you tell some orthopnea and PND are fairly specific for
heart disease, ma'am.
heart disease,
Yes, ma'am.
and PND is specific for left-sided failure. Orthopnea also, but orthopnea can be seen in other right-sided diseases also.
Yes,
okay. So now you tell me, what are the other causes for orthopnea?
The patient can have in cardiac condition, ma'am.
No. Orthopnea is fairly specific, but there are other causes for orthopnea. And another 3 causes you should know. Respiratory, right?
Respiratory. Massive pleural effusions can cause immediate.
Yeah, any respiratory cause, acute asthma.
Asthma.
They won't be able to like that. Then, anything abdominal?
Massive ascites that can elevate the diaphragm, and then it can cause.
Massive ascites, yes.
Yes.
Third, you talk something about diaphragm. Anything related to diaphragm? Bilateral diaphragmatic palsy. Bilateral diaphragmatic palsy. These 3 things you should remember. Respiratory causes, massive ascites. Ascites could be due to right heart failure, constrictive pericarditis, or any abdominal cause.
Yes.
Then bilateral diaphragmatic palsy. Okay. So now you tell me what are the mechanisms for orthopnea?
Mechanism of orthopnea, once the patient lies down, all the interstitial fluid comes back into the intravascular compartment. And once it comes into the intravascular compartment, there is, because of LV failure, the LV is unable to pump, ma'am. So there is increase in the pulmonary pressure, pulmonary capillary pressure, wedge pressure, that causes dyspnea.
See, orthopnea occurs as soon as the patient goes into supine position. So it has to be in the intravascular compartment already.
Yes, ma'am.
Okay, it is not interstitial, it's already in the intravascular compartment. When we stand or sit or put our legs down, about 500 to 800 ml of blood will be pooled in the splanchnic circulation as well as in the lower limbs. So when we lie down, because of the gravity, this volume of blood goes to the lungs. Okay, it's already in the intravascular compartment.
Yes, ma'am.
Okay.
Yes, ma'am.
So the failing heart, see, this can occur only when the right ventricle is functioning normally. The right ventricle is dysfunctional, then this cannot reach the lungs.
Yes, ma'am.
So if the right ventricle is normal, then this is pumped into the pulmonary circulation. And normally the LV can accommodate the extra volume, but failing left ventricle cannot accept. So the pulmonary venous pressure goes up. There may be interstitial edema. Then it may result in even increase.
Intravalvular edema.
Yes. So they get immediately become breathless and they sit up. Usually it's interstitial. So once they, what is the other mechanism? One is increased venous return, which is already in the system. Second is elevation of the diaphragm.
Yes,
okay, these are the 2 important mechanisms for orthopnea.
yes, ma'am.
Once they sit up, the symptom is relieved.
Yes, ma'am.
Okay. Then next, what are the mechanisms of PND?
PND, there is reduced.
PND, the most important mechanism is what you told,
Yes,
absorption of the interstitial fluid into the intravascular compartment.
compartment.
That is why it takes 2 to 3 hours.
Yes. Yes.
Okay. Orthopnea, it's already there. PND, it's absorption of the
Yeah.
interstitial fluid into the intravascular compartment. Again, here the right ventricle should be normal.
Yes, ma'am.
So it goes to the left side. That is the most important mechanism. There are other mechanisms.
Reduced sympathetic drive.
Yes, decrease sympathetic drive, which will decrease the left ventricular function.
Then one more is reduced hypoxemia that can occur.
Decrease respiratory drive also during sleep. Then sometimes, as you said, REM sleep, you said you doing REM sleep. So during that time, there may be dream or
surgeon.
Yeah, there can be increased sympathetic, increased increase in heart rate, tachycardia, those things.
Yes,
And also sometimes arrhythmias, nocturnal arrhythmias. So these are some of the precipitating factors. The most important is absorption of interstitial fluid. So PND is fairly specific for left-sided failure,
Yes,
but it can, some conditions can mimic PND. Can you mention some of them? Because when you take, correct, nocturnal asthma, though it occurs little later in the early morning hours, then
nocturnal angina can also present like
sometimes. More important, see, most of them are respiratory. Can you tell some more respiratory causes like? Correct, obstructive sleep apnea. Then postnasal discharge.
Yes.
That can cause some bronchospasm, like that esophageal reflux, bronchospasm. So some of they may say, oh, I get dyspnea, cough after sleeping and I get up from bed because of this. So you have to differentiate these things from PND. Once you think it is PND, it has to be left-sided failure. You can't think of other things. Okay. So this patient has PND and orthopnea. PND comes earlier in the natural history.
Yes, ma'am.
And orthopnea indicates more advanced
LV failure.
heart failure.
Yes.
Okay. So now, is she better after developing edema?
She feels better. She feels better after developing edema.
Once they develop right-sided symptoms of left-sided failure like orthopnea and PND comes down. Okay.
Yes, ma'am.
So any other things related to dyspnea? Anything else? Few things which may be asked like what is platypnea, hypopnea? You know or not?
Yes, ma'am. Platypnea is when the patient feels dyspneic on sitting up from supine posture.
Sitting or standing?
Standing. That usually is accompanied by an orthodeoxia on the.
Okay. It may occur in patent foramen ovale or some pulmonary AV
It requires an anatomical and a functional. It requires an anatomical shunt and a functional component, ma'am. So.
Okay, fine. Then there is something called hypopnea, where there is dyspnea
on lateral positions, on patient lying on lateral position.
Yeah, it may be cardiac or respiratory.
No, respiratory.
Okay. So one more fairly recently described symptom. Bendopnea, correct. Bendopnea is again a symptom of
cardiac
left-sided failure. Suppose not respiratory, left-sided failure. It indicates it leads to increase in left ventricular end-diastolic pressure, and patient can have dyspnea because of this. Yes, so bendopnea is again a symptom of left-sided failure. Yes, okay. Now you decide that this is cardiac origin dyspnea and patient is in class 4. Yes, okay, move on to the what is it? Bendopnea. B-E-N. Yes. Somebody is asking ventop. B-E-N. Bending forward. You know how it is brought out? When do you bend generally? Tying shoes. Bendopnea, correct. Shoelace, correct. Yeah. Okay. Yes, Sanjay. Okay, Sanjay. Yes. So next symptom is palpitation. What is palpitation?
Palpitation is unpleasant awareness of one's own heartbeat.
Okay. So can you tell me the three basic mechanisms of palpitation?
It can be because of increase in the heart rate. It can be increase in the volume of contraction. It can be increase.
Change in the rate. Change in the rate. That is increased heart rate or decreased heart rate. Change in the rhythm.
Or force of
Or
contraction.
increased force of contraction. Correct. So how do you go about history of palpitation? You have to decide whether it is arrhythmic palpitation or due to volume overload. Can you mention all the causes for palpitation?
Yes, ma'am.
This is the mechanism we discussed. What are the causes?
So, coming to the rate, it can be either a bradycardia or a tachycardia, ma'am. So, if it is a bradycardia, usually either a severe sinus bradycardia or.
That's okay. That's okay. That's okay. The cardiac causes could be arrhythmic or volume overload or increased force of contraction. There are some. See, hardly 50%, 45% of palpitations are supposed to be cardiac origin. There are other causes for palpitation.
Second can be anemia, which is common, ma'am. Then there can be thyroid diseases.
Okay, non-cardiac diseases like anemia, hyperthyroidism. Okay, next.
Then there can be anxiety and panic attacks.
Correct. Anxiety. Correct. Anxiety. Okay. So it's a non-specific symptom.
Non-specific symptom, yes, ma'am.
So now, how do you decide whether it is arrhythmic or volume overload?
So we ask the patient whether first is if we can demonstrate whether it was regular or irregular first.
Very good. Yeah. If your patient can tell that it is irregular, then it is likely to be arrhythmic. Yeah. Somebody is telling you can tap and ask the patient whether it is regular, irregular. They may sometimes say it's like a misbeat or something fluttering inside. Yeah. Then if it is sudden onset and sudden offset,
then we can think of paroxysmal, this one like
correct.
Paroxysmal arrhythmias.
If it is associated with syncope, again it is a more ominous symptom. Yeah, it could be some ventricular arrhythmias. So those are the things which
slow onset maybe associated with sinus tachycardia.
Correct. One more thing you should remember: atrial fibrillation. They may not notice irregularity. So just because it is regular, you cannot rule out atrial fibrillation. And long-standing atrial fibrillation, they may not have palpitation because if they have a controlled ventricular rate, they may not experience palpitation. Third, they can have palpitation and exertion even in atrial fibrillation because heart rate increases, increased sympathetic activity, increased AV conduction, so they can have palpitation and exertion. So atrial fibrillation can have irregular palpitation, or regular palpitation, or exertional palpitation, or there may not be any palpitation. So you should be careful. You cannot rule out atrial fibrillation based on regularity or absence of palpitation. So in general, volume overload palpitations occur at rest, may increase on exertion. They may have kind of pounding sensation. So here, what do you think is the mechanism of palpitation?
Here, I'm thinking it is because of force of contraction that the patient is feeling.
What are the conditions which can cause increased force of contraction and palpitation?
Force of contraction can be increased whenever there is a increased volume overload conditions like mitral regurgitation or aortic regurgitation.
Okay. Any other cardiac conditions?
Shunt, like asynotic congenital heart disease, they can
shunt
have
lesions. You better say shunt lesions like VSD, moderate to large VSD or PDA, where there is LV volume overload. ASD, there is RV volume overload. They may have palpitation. ASD more often is because of atrial arrhythmias in late stages, but it is mentioned. Okay. Then non-cardiac causes like all your hyperdynamic circulations, including anemia. AV fistula. So they can also have palpitation. Okay. So what is the significance of palpitation in patients with valvular lesions? Which patients are likely to have palpitation as an early symptom?
Patients with mitral regurgitation and aortic regurgitation will have palpitations early than breathlessness.
Correct. MR, severe MR, they may have volume overload of LV and have palpitation. In fact, in aortic regurgitation, they may have just palpitation and some pounding sensation in the chest for years before they develop other symptoms. So here, the palpitation is started 3 months after the onset of dyspnea. How do you interpret that history? See, if it is due to volume overload, it should have been there before.
Yes, ma'am.
Here it is started after the onset of dyspnea. So it's not really easy to attribute it to volume overload. Okay.
Okay. One could be volume overload. One could be patient might be having arrhythmia that patient feels it is present throughout.
See, usually volume overload palpitation comes before the onset of dyspnea. We are discussing, right?
Yes,
So if you think it is due to volume overload, it has to be either MR or AR.
yes, ma'am.
Okay. Either they should have history of palpitation much before the onset of dyspnea, or sometimes with MR, onset of atrial fibrillation can push them into failure. So palpitation can occur almost simultaneously with the dyspnea. It can suddenly, they can develop left-sided failure because of atrial fibrillation. But it's occurring 3 months later. It's unlikely that it is, if the history is correct, it is difficult to attribute it to the volume overload. Okay, fine. Next symptom is
swelling of pedal edema, bilateral pitting painless pedal edema up till the.
Somebody is asking, can stenosis cause palpitation? Generally, stenosis is unlikely to cause palpitation. In mitral stenosis, if they develop palpitation, it is more often because of atrial fibrillation. And in aortic stenosis, if they develop palpitation, it may be because of arrhythmias like ventricular ectopics or late stages atrial fibrillation. Generally, they don't develop palpitation unless they have some arrhythmias. Does it answer your question?
Yes, ma'am.
Okay. Okay. So the next symptom you said is bilateral pedal edema.
Yes, ma'am.
That is from last 1 week, you said.
Yes, ma'am.
So patient did not go to any doctor during the last 6 months?
She had been to the
Anyway,
doctor.
you're going to tell that. Okay. So edema indicates that patient has gone into right-sided failure.
Yes, right-sided failure.
Okay. Okay, go on with the other history.
So there is no history of pain, post palpitation, diuresis, or syncope. There is no history of fever. There is no
What is
history
the significance of this post palpitation diuresis?
It suggests that there can be paroxysmal arrhythmias will have usually post palpitational diuresis.
What arrhythmias cause diuresis?
Like AVNRT or AVRT, they can.
It's usually atrial arrhythmias, right?
Arrhythmias, yes,
yeah, atrial tachycardia, because there will be increased secretion of
ANP and BNP level.
at atrial natriuretic peptide that causes polyuria.
Yes, ma'am.
So that occurs in paroxysmal palpitations. Okay, fine. There is no history of syncope.
There is no history of any fever. There is no history of abdominal pain or yellowish discoloration of the eyes. There is no history of any squatting episodes in the childhood or bluish discoloration of the body that is noticed in the childhood.
Wait. I just interrupt you here.
Yes, ma'am.
I agree with you the history of fever because
infective endocarditis is one that has to be ruled out.
One is infective endocarditis. Second, maybe any respiratory infection can worsen the
symptoms.
Yeah. Okay. Second, abdominal pain, yellowish discoloration is okay. You are thinking of right heart failure anyway, so they can have okay. This fatting episode. What is the age of the patient?
Patient is 50, ma'am.
50 years?
In
Okay.
childhood, like past history, we wanted to ask.
No, it should be relevant.
Relevant.
Okay. So very unlikely that a patient with cyanotic heart disease
Has
will
been
live up to this age without any symptoms. They can live. See, top 3% of them can live beyond 40 years, but they will have symptoms. So it's unlikely that patient was asymptomatic just till 6 months back. So that when you take past history, it should be relevant. Okay. So squatting you expect in a patient with the top physiology. So top physiology will have symptoms. Okay, fine. Go ahead.
There is no history of cough or hemoptysis. There is no history of any facial edema, reduced urine output, or abdominal distension that was noted. Past history, there is
Any
no.
other any other history is important? Nocturia. Have you heard of nocturia?
Yes, ma'am.
So is nocturia common in heart failure?
It's common in heart failure, ma'am.
Yeah, because at rest or while sleeping, the renal blood flow improves. So urine formation is more during night. So they may have nocturia. It's an early symptom of heart failure.
Yes, ma'am. Here in the the history of presenting illness, when the patient developed PND, patient had gone to a local hospital and she was told to have a heart disease that may require surgery, and since then she was put on oral medications. The patient says the patient was taking medications, after which the symptoms reduced, but then she's been irregularly on medications, and following this, since 1 week, this pedal edema and all has worsened and breathlessness has worsened.
Did she take medications?
When she took medications, ma'am, when she took medication, she was feeling comfortable.
Then
But
she stopped.
then she stopped, and since
Oh.
this 3 weeks,
Okay.
again the symptoms have worsened.
Fine.
Past history, there is no history of fever, migratory joint pain, or involuntary movements or rashes in the childhood. There is no history of type 2 diabetes, hypertension, asthma, tuberculosis. There's no history of hospitalizations or surgeries. The patient was only given oral medications on OPD basis. However, was told to have a heart disease and was told to get evaluated at a higher center.
When was she told to have heart disease?
When
Only
patient
during this, yeah,
PND,
before, during younger age or during, okay. She was never diagnosed to have heart disease.
diagnosed to have heart disease in the childhood, ma'am. Only now she's got to know that patient might require a heart disease. A patient is born of a non-consanguineous marriage. There is no family history of sudden cardiac death or heart diseases in the family.
Okay, what is the significance of non-consanguinity here?
Consanguinity, if there is consanguinity, there can be chances of congenital heart disease that can run.
Anyway, it's more important in congenital heart disease. Okay, next, sudden cardiac death. Okay. Okay.
Yes,
Finished or any more history you have? Personal history. Okay.
yes, ma'am. Personal history: patient consumes a vegetarian diet with the appetite has been reduced since 1 month with disturbed sleep. Bowel bladder habits have been regular and denies any high-risk behavior or addictive habits. Patient has been irregularly on oral medications with no known drug allergies. So, summarizing.
Wait. What, anybody? What important history is missed? Anybody? Is a female.
Menstrual history.
Not that. More important than that. History of pregnancy and childbirth.
Okay.
Huh?
Yes,
In a female, anyway, she is 54. Still, it is. Is it important or not?
important, like lesions can worsen during pregnancy, like stenotic lesions may worsen during pregnancy.
Maybe little more important when they are younger. They present at 30 years or so, but still, you should include in a female history of pregnancies, any worsening. That is the time they can, the lesion can be detected, right?
Yes, ma'am.
Okay. So that history you should include in a patient.
Yes, ma'am.
So summarize.
Yes, ma'am. So my patient, a middle-aged lady with a background history of a known heart disease, diagnosed about 3 months back, presented with progressive breathlessness since 6 months, which was initially in grade 2 NYHA and currently in grade 4 NYHA.
One second. This NYHA is not grade, it is class. Okay?
Class 2, yes, class 2 to class 4 NYHA with exertional regular palpitations and pedal edema since past 1 week. So I would like to consider the following possibilities. So one possibility.
Did you ask whether this patient had palpitation before? Did you ask? Sometimes you'll have to ask leading questions.
A patient denied any history prior, ma'am.
Okay.
Before this, any breathlessness, she said breathlessness initially started. There is no history of any palpitations that she had prior.
Fine.
A possibility is because she's in the 5th decade of life. So possibility is one is patient might have an ischemic heart disease and currently in congestive cardiac failure. One more possibility is a valvular heart disease. Now currently in congestive cardiac failure. Because of the history of palpitation that was there, I'm thinking of a regurgitant lesions, probably more of mitral valve than the aortic valve, because of the age of the patient being 50 years. The one more differential I would like to think of is an adult acyanotic congenital heart disease, mainly the shunt lesions, left to right shunts, that are now presenting with failure.
Coming to one by one. Okay, why did you put ischemic heart disease first?
Because patient is in the 5th decade of life.
Any risk factors you asked? Any risk factors are there?
She doesn't have any risk factors for
this. So no angina. Okay, you have to consider.
Yes,
but without risk factors, without any history of angina, less likely. Okay. Postmenopausal woman. Yes, you can, but that's the only thing. Yeah. Then
the second possibility is
if it is valvular heart disease. Yes, see, in our country, still rheumatic heart disease is common. They can present in 4th, 5th, 6th decade also. Yes, so you have to keep
rheumatic heart disease in the.
Yes, rheumatic heart disease. But she was asymptomatic all through.
Unlikely, like for maybe asymptomatic period was.
Yeah, see, there are some precipitating factors. They can be asymptomatic. And there are some precipitating. Are you aware of some precipitating factors which can worsen the symptoms?
One is the severe development of severity of the lesion. One is the arrhythmia that can worsen.
That is progressive. See, patient is stable, and one day patient comes with heart failure like this. So 2 things most common. One is infection. Second is arrhythmia, especially atrial fibrillation in a patient with mitral valve disease. Okay, these are 2 common things. Then there are some 8, 10 in the. Your Harrison gives all those things like.
One is ischemia, ma'am.
Ischemia, hypertension, thyrotoxicosis, anemia.
Many the comorbidities that can be there that will worsen the.
Anyway, you read and tell in the next class what are the precipitating factors. You should always include this whenever you write the final diagnosis. Is there any precipitating factor? Infective endocarditis, rheumatic activity in a younger patient. All these can be a precipitating factor. Then non-compliance with drugs, non-compliance with diet.
Yes.
Okay. Make a list and tell in the next class. Okay. So it could still be a left-sided valvular lesion, correct? Mitral stenosis is unlikely because the history is short. And history of palpitation, which has come later in the natural history here. I'm not sure whether that can contribute to the regurgitant lesion history. Okay. Next is congenital. Which congenital heart disease can present at this age? You are right. You have to bring the palpitation. No?
ASD and VSD can present at this
No
age.
VSD. VSD will not present so late. It's ASD.
40 to 40.
So it's ostium secundum or sinus venosus ASDs. They present usually after the 4th decade. But what is against that diagnosis here?
Palpitations usually will be there long-standing
Palpitation could be because of atrial arrhythmias. Very common after 40 years, the incidence of atrial arrhythmias
the
goes up.
failure symptoms, they may not.
They will not have left-sided symptoms.
Yes, ma'am.
Like PND is against AS.
Yes, ma'am.
Okay, correct. They will have right heart failure. They will not have symptoms of left heart failure, especially if there is history of PND that rules out atrial septal. Anything else you can think of? Cardiomyopathy.
Cardiomyopathy, yes, ma'am.
6 months history. You should include dilated cardiomyopathy or even restrictive cardiomyopathies. Cardiomyopathies. Can it be hypertrophic cardiomyopathy?
Usually, like they might have symptoms earlier than this.
They may have symptoms earlier. Yeah. So that is 6 months history. You have to bring in myocardial disease. Okay, go ahead. Any doubts so far? Anybody? We are supposed to finish at 7:30.
We can go a little more, ma'am. No problem.
Okay, we'll see how it goes.
Ma'am, time is not a constraint, ma'am. We can please continue, cover this entire topic, please, ma'am.
I hope you won't.
Discussion is going on very well, ma'am. Thank you.
Okay. Whenever you're getting.
No, not at all, ma'am. Not at all. Not at all.
Okay.
No, ma'am. No, you are learning still the basics, ma'am. It's so good. Nice. Thank you.
Okay, fine. Then
we have a middle-aged female who's well built and nourished, well oriented to time, place, and person. On examination, there was bilateral pitting pedal edema up till the mid calf that was noted.
see, before that, 1 second, I want to interrupt you. Don't you take some height, V8 and BMI?
BMI, forgot to mention, ma'am. I've taken, ma'am.
Taken.
Yes, ma'am.
No, if the patient is in front of us, it's okay. But if we don't see the patient, better you mention the BMI.
Yes, ma'am. Yes, ma'am.
It's okay.
Yes, ma'am.
We believe you.
There is no pyelorectus sinuses clubbing lymphadenopathy. Blood pressure in the right upper limb was 130 by 70 millimeter of mercury. In the left upper limb, it was 138 by 70 millimeter of mercury. In the right lower limb, it was 158 by 74 millimeter of mercury. And the left lower limb, it was 158 by 74. This the impression is that the Hill sinus is positive.
So you interpret this blood pressure.
Yes, ma'am.
What has happened to the systolic pressure, diastolic pressure, pulse pressure?
Wide pulse pressure. The systolic BP is normal, ma'am.
Systolic BP normal.
Yes, ma'am.
130. What do you expect if it is? See, when you say Hill sign, you expect a significant aortic regurgitation. What happens in aortic regurgitation?
In aortic regurgitation, the systolic blood pressure will be very high, more than 150, 160. And
don't say very high, it will go beyond 140.
140, yes.
160.
Beyond
Like
140.
Yeah. So it will be
diastolic is, we expect a diastolic runoff to be present.
Diastolic pressure will be lower.
Lower,
and you'll have a wide pulse pressure. So here systolic pressure is not really high, it is normal. Then diastolic pressure is also not very low, it is 70. When you say significant aortic regurgitation, diastolic pressure will be less than 50, 40 like that. Okay. But you have a pulse pressure of 60. What is the normal pulse pressure? That too in the right. Huh?
Up to 20 is normal, 20 to 30 is normal.
Pulse pressure 30 to
40.
60. Some books say 50, 30 to 50, 30 to 60. Okay, 50 is okay. So it is just upper limit of normal. Yes. What is proportional pulse pressure?
I'm not sure.
Proportional pulse pressure is very important. This will give you an idea about the cardiac output. See what happens to pulse pressure when there is low cardiac output?
It will
narrow, right? Yes. Narrow. So if you take a ratio of pulse pressure to the systolic pressure, and if it is less than 25%, it indicates that the cardiac index is less than 2.2 liter per meter square. Okay. So here it is. Pulse pressure is on the wider side. Okay.
Here we have a wide pulse pressure, ma'am. But
It's
what
not
we
really wide, Vijay. The 130, 70. What is the difference between right and left upper limb? Is it accepted or how much is accepted?
up to 10 they say is okay, ma'am.
Correct. Yeah, the difference between usually right upper limb is pressure is higher than the left upper limb by about 10 millimeter, up to 10, because it's in a dominant. If the right sided dominance is there, then it is more in the right side. Okay. Anything more than 10 is significant. So lower limb, how did you measure the lower limb blood pressure?
Ask the patient to lie on his prone position and tied the BP cuff, ma'am. He didn't get a bigger size cuff.
So you use the same cuff, huh?
Yes, ma'am.
Same cuff, if you put it on the thigh, what happens to the blood pressure?
It may be falsely elevated, ma'am.
Correct. So you should not put it on the thigh and you will never get a bigger cuff. So you use the same cuff in supine position over the calf.
Yeah.
Okay. Calf and palpate the dorsalis pedis or posterior tibial. We are not interested in diastolic pressure. We are interested in systolic pressure, right? So you can use dorsalis pedis or posterior tibial to measure the systolic pressure. So if you put it on the thigh, invariably you get a higher pressure. Okay. Now how much is your hill sign? This is wrong anyway. How much is your hill sign? 28.
Yes, ma'am.
Okay. So how do you grade AR based on hill sign?
Based on the whether 20, the difference between the upright.
Everybody knows, no? What is hill sign? Somebody can answer. What is hill sign? Hill sign is, you tell Vijay.
Yes, ma'am. The difference between the right difference between the upper limb and lower limb pressures, ma'am.
Systolic blood pressure, difference between the upper limb and lower limb. Usually upper limb pressure,
Will be lower.
lower limb pressure is up
More
to
than-
10 to 20 millimeter mercury more than the upper limb pressure. Okay. Suppose upper limb pressure is 120, lower limb pressure can go up to 140. So if it is more than 20, the difference between systolic pressure in the upper limb and lower limb more than 20, that is hill sign. So classically seen in aortic regurgitation or any other situation where there is central runoff. We will come to that. So 20 to 40 is mild, 40 to 60 is moderate,
more than
above 60 is severe. What is the current controversy about this hill sign? Are you aware?
No, I'm not aware of it.
Actually, if you measure the intra-arterial pressure, there is no difference between the upper limb pressure and the lower limb pressure.
Okay.
So what they say is it is a sphygmomanometric artifact. So, but still it is valid in assessing the severity of AR. You can still use it, though it is intra-arterially, there is no blood pressure difference. We also done in few patients.
Yes, ma'am.
Aortic regurgitation. There was no significant difference in the intra-arterial pressure between the upper limb and lower limb. But still, clinically, this is a helpful sign. Okay.
Yes,
but you should measure it properly using a proper cuff size.
yes, ma'am.
Otherwise, you will be overestimating the upper limb blood pressure.
Yes, ma'am.
Then you use a smaller cuff for a bigger arm or a bigger thigh. You will be overestimating the blood pressure. Okay. So it's not very impressive. It's around 28. And if you take the upper limb, left upper limb and left lower limb, it is hardly 20. So not very impressive difference.
Yes, ma'am.
And other thing is you don't have to take blood pressure in both lower limbs. One lower limb is enough unless there is difference in the pulse volume. Okay.
Coming to the
So,
pulse. Yes, ma'am.
yeah. The only thing what I can see is there is some widening of the pulse pressure. Why there is high systolic pressure in AR?
Because during the diastole there is a run of from the aorta into the ventricle.
Why systolic pressure is high? Why diastolic pressure is low?
Yes, ma'am. Diastolic pressure is low because of there is a regurgitation that happens during diastole, ma'am. The diastolic runoff occurs in aortic regurgitation that reduces the diastole. Systolic pressure because there is increased end diastolic volume. LV end diastolic volume is high in.
The rapid ejection of large amount of blood, right?
Yes, ma'am.
See they can have 3-4 times the normal
Yes, ma'am.
stroke volume. So there is a rapid ejection of large amount of blood. So that causes
High systolic
increase in the systolic pressure. Why there is low diastolic pressure? That is because of peripheral vasodilatation. Why there is peripheral vasodilatation? Because there is a large amount of blood ejected into the aorta. The reflex vasodilatation. Okay.
Yes, ma'am.
It's a reflex mediated systemic vasodilatation. So there is low diastolic blood pressure. So when these findings will be reduced, classical findings of high
Whenever there is
systolic pressure, low diastolic pressure, wide pulse pressure will not be present in AR.
if there is a coexisting stenosis that is there, they may lose that.
Okay, one is other valvular lesions like severe aortic stenosis, severe MR, severe mitral stenosis.
Yes,
It doesn't allow the
systolic blood pressure to
systolic volume to increase, ejection to increase. Okay. Second,
if patient develops congestive failure, then it may
LV
not.
dysfunction. When they develop LV dysfunction, LV end diastolic pressure goes up.
Then
So
the pressures drop.
they start developing systemic vasoconstriction and the diastolic pressure will go up. Third, acute aortic regurgitation. Acute AR, there is no time for the compensatory mechanisms to occur. So you don't get all these findings in acute AR. So acute AR, LV dysfunction associated with the findings of this wide pulse pressure and high systolic and low diastolic. Okay.
Yes,
Go ahead.
coming to the pulse was 87 beats per minute, regular in nature, high volume, non-collapsing. The character was pulses bispherians, no thickened vessel wall, all peripheral pulses were well felt. There was no radial or femoral delay that was present.
Here only abnormal thing you have picked up is high volume.
High volume, ma'am.
But you said
non-collapsing.
You said bispherians pulse. Where is it? Okay. What is this bispherians pulse, Vijay?
Bispherians is when we feel two peaks in the pulse, ma'am, and both are in the systole.
Good. So what is this first peak and what is the second peak?
First peak is because of secondary to the ejection of the blood from the aorta, the pressure wave, ma'am.
Or percussion.
Percussion.
Right?
Percussion.
So that is because of rapid ejection of large amount of. Okay. Second peak is because of.
Second peak is because of the elasticity of the reflection from the aorta, ma'am.
Correct. Yeah, tidal wave. That is because of reflected waves from the periphery. Okay. There is other explanation for this. You can read.
Okay.
So it could be because of anything, Venturi effect.
Venturi effect. Yes, ma'am.
Because of Venturi effect.
Yes, ma'am.
Okay. Anyway, we'll not go into that. Usually, what answer expected is it's reflected wave from the periphery. Okay. So bispherians was classically seen in
aortic stenosis with aortic regurgitation. Or
get in AR?
AR or AS with AR?
No, classically seen in severe aortic regurgitation. You can have it in AS, AR also. Again, AR will be dominant there. Okay. Third answer which you will give is HOS, hypertrophic obstructive cardiomyopathy. But here, usually it is recorded rather than felt. Okay. So You get a brisk pulse.
Yes, ma'am.
Yeah. Classically, pulse is brisk in hypertrophic obstructive cardiomyopathy. And the first peak will be taller than the second. Whereas in AR, both may be equal or the second may be taller than the first. Okay, go on. Somebody is asking whether you had other abnormal pulses like Corrigan pulse.
I didn't have any other peripheral signs, ma'am. Peripheral Corrigan's, water hammer, we didn't have.
What is the difference between water hammer and collapsing? Both are same actually.
Same.
Yeah. But water hammer they say is upstroke and the collapsing is downstroke. Anyway, it's hair splitting. So anything else? Among all the peripheral signs, which are the two important peripheral signs in aortic regurgitation?
One is Hill sign, ma'am. That will
Very
help us
good.
estimate the
Yeah, you can assess the
severity.
severity. Correct. Second, durosis murmur. Durosis murmur.
Okay.
Do you know what is durosis murmur?
Yes, ma'am. We asked the, it is seen in the femoral artery where we place the diaphragm of the stent in the femoral artery, and we do a proximal and distal occlusion and see the murmur flow, ma'am. Whether there is a
So
diastolic.
if you press the femoral artery proximally, you get a systolic murmur because you're obstructing the forward flow.
Yes, ma'am.
Okay.
Yes, ma'am.
If you obstruct distally with your diaphragm, you get a diastolic flow. So that is more important because you're trying to obstruct the retrograde flow, that is central runoff. So this is a sign of central runoff. You're trying to obstruct the flow.
Yes,
So you get a diastolic murmur. So this is a important sign to pick up the conditions in central runoff. Most common is AR. You may get it in ruptured sinus of Valsalva, PDA with large left to right shunt. Okay, whenever there is central runoff. Central runoff means regurgitation. Or what is difference between pulses, bispherians and dicrotic pulse? So the dicrotic pulse is, Vijay, can you answer that question?
Dicrotic pulse, there is only one peak in systole and it is
the second peak is in diastole. So in bispherians, both the peaks are in systole, whereas in dicrotic, sorry, what is that? Dicrotic pulse. Huh?
Yes, ma'am.
So one peak in systole, other in diastole. So it is seen more often in medical conditions like sepsis, enteric fever. Can also occur in severe congestive heart failure. Okay.
Yes.
Thank you. Go ahead.
JVP was normal and not elevated above the sternal angle.
But I can't believe this. Who examined the patient?
I only examined, ma'am. Patient was started on diuretics by the time I had seen, ma'am.
But you said edema is there.
No, edema was there, ma'am. Patient was started on diuretics.
Which is the last one to disappear. Edema disappears early. JP will be persisting.
Okay, ma'am.
Anyway, I can't confirm now. So next time you record and show them.
With
How did you examine the JP?
The patient was lying on the bed and the bed was made at an angle of 45 degrees, ma'am. And
can you miss the 45 degree?
Ma'am?
Can you miss the JP in 45 degree?
It missed, ma'am. So we'll have to put him further positioning at 60 or 30 degrees.
Why do you put in 45 degree? Just 1 minute we'll spend in JP because I am sure it was missed.
Okay, ma'am.
Huh?
Yes, ma'am.
Why 45 degree? Why not supine position? Why not sitting position?
If the patient is lying supine, ma'am, then the pulsations will not be seen normally, ma'am.
Yeah, in supine position, the upper level of the JP will be intracranial, so you'll not see the upper level.
Yes, ma'am.
In supine position, sitting position,
It may be just below the clavicle.
Intrathoracic. So you will not see the upper level. I am talking about the normal JVP. So in normal JVP will not be seen in sitting posture or in supine position. It will be intracranial upper level. So you put the patient in 45 degree. You will see the upper level then somewhere in the middle of the neck. Okay. Suppose if the JVP is elevated and you put the patient in 45 degree, the upper level will be maybe intracranial. So you can miss it.
Okay.
Ideally, nowadays in cardiology, what is advised is you make the patient sit.
Okay.
If you don't see the upper level of JVP, it is not elevated.
Okay.
Okay. If it is seen above the clavicle, then you can measure the vertical height from the sternal angle. Okay. Suppose you don't see and you want to look at the waveforms, JVP is not just the elevation, you have to look at the waveforms, you have to see the respiratory variation.
Okay.
So you can put the patient in 45 degree or whichever position you can see the upper level. So the most important is you should see the upper level. Here, I'm sure if you had put the patient in sitting posture, you might have seen the JVP upper level. I don't know whether it's beyond the neck or beyond the mandible. Yeah. Okay. The other thing is, if the JVP is normal, what else you would do?
Into the hepatojugular to see
Yes. Yes. So even if it is not elevated, you have to look at the
the hepatojugular reflex.
waveforms. See, there are 4 or 5 things you have to see in JVP. One, whether it's elevated or not, how much it is elevated, what are the waveforms, what is the respiratory variation. So normally what happens during respiration?
Normally during respiration, the JVP, there is increase in the venous return, ma'am.
Yes.
So
But
then
there is fall in the intrathoracic pressure. So the blood gets sucked into the
respiration, there will be reduction in
right
the
side. So there will be a fall in
right side.
mean pressure by around 3 millimeter mercury during inspiration.
Yes, ma'am.
Okay. You have to look for that. During normal inspiration, it falls by 3 millimeter mercury. If it doesn't fall or if it increases during inspiration, that is called
Small sign.
small sign and it's a feature of right heart failure. It's classically described in what?
Pericarditis.
Constrictive pericarditis, but the most common cause is right heart failure. So that is other thing. And if you think JP is normal, you have to, and you're suspecting right heart failure, you have to do abdominojugular reflex. How do you do that?
Ask the ask the patient to lie supine or with an angle, ma'am.
May not be supine because you have to see the
30 to
upper
40
level.
degree with the 30 to 40 degree.
Yeah, at least 45 degree, you should see the upper level. It goes up.
Yes, ma'am.
Yeah. Okay.
Then we apply a sustained pressure in the right.
Before that, what will you tell the patient?
We'll tell the patient that we'll be applying the pressure over the right upper quadrant, and patient may have pain or may not have pain with that.
So you need not apply over the right upper quadrant. You can apply over the upper abdomen because if the liver is tender, then what happens? See, if you go and press the abdomen, patient will do Valsalva.
Yes, ma'am.
Correct. Above the umbilicus. Yeah. Periumbilicus. Okay. Yeah. The idea is what?
To increase the venous return.
Correct. It is not a reflex. It is abdominal reflux. FLUX. So you should compress for 10 to 15 seconds. Periumbilical region.
And see for the sustained rise in the JVP.
Waveforms. I think we'll have in the next class we'll discuss because
Yes, ma'am.
it's already 7:15. Somebody is asking. Next class we'll discuss about JVP.
Yes, ma'am.
So you should do when there is suspected right heart failure. So incipient failure, there will be persistent elevation of JVP by more than 3 centimeter throughout your compression. Suppose RV is normal or it's a normal hepatojugular reflux, then there will be transient elevation less than 3 centimeter, maybe 1 centimeter or so. Within 2-3 beats, it will be
Come back to normal.
Back to normal. So that is an important sign to elicit. Okay, it also correlates with the left ventricular end diastolic pressure of more than 15 millimeter mercury. If you have a positive hepatojugular reflex, the LV end diastolic pressure will be more than 15 millimeter mercury. This patient, we are expecting a LV end diastolic pressure more than 25 because patient has orthopnea.
Yes, ma'am.
Okay. I'm sure JP also will be elevated. Okay, go ahead.
Coming to the cardiac examination, on inspection, there is no thoracic wall abnormalities or precordial bulge. The trachea was central. The apex beat was visualized in the left sixth intercostal space, 2 centimeter lateral to the mid-clavicular line, ma'am.
Okay.
There is no scar, sinuses, or venous engorgement or any other pulsations that was noticed. Palpation, there is no tenderness. Apical impulse was confirmed. The location was in the left sixth intercostal space, 2 centimeter lateral to the mid-clavicular line, which is hyperdynamic in nature. The diastolic thrill was felt in the left third intercostal space. There's no suprasternal, epigastric, or interscapular impulses that were felt.
Once again, I'll interrupt you here. Usually in cardiology, we combine inspection and palpation because,
Okay.
yeah, here it's okay. Inspection, 3 things what you see is, one is
The mediastinum, the trachea.
whether there is any chest deformities. All those pectus excavatum, pectus carinatum, even the kyphoscoliosis, all these can alter the findings.
Yes,
second, any scars. Did you mention the scars?
Yes, ma'am, I mentioned no scar, sinuses, or venous.
What are the scars you look for? It's not just some wound scar or anything. It's a previous surgery scar. Is there any mid-sternotomy scar? Is there any lateral thoracotomy scar or posterolateral thoracotomy scar? We'll discuss that later. So any scars. Third is pulsations. You start pulsations, apical impulse, left parasternal pulsations, any other pulsations. Supraclavicular or suprasternal also you can include here or during general examination. Okay. Now, don't tell inspectory findings are confirmed. You have to tell what is the palpatory findings are different from inspectory findings. So apical impulse is in the left sixth intercostal space, 2 centimeter.
Lateral to the
lateral or medial?
Lateral, ma'am, lateral.
You left that. Okay, fine. Lateral to mid-clavicular line, and it is hyperdynamic. So what does it mean?
It indicates a volume overload, ma'am.
It doesn't indicate. Okay, before that, is there a cardiomegaly or not?
It indicates cardiomegaly, ma'am.
Can you describe a normal apical impulse for the benefit of?
The normal apical impulse, the location is in the left fifth intercostal space.
1 second, somebody is asking whether we should mention signs of infective endocarditis. If there is no history of fever and there is no clinically you are not suspecting history-wise, generally there is no need because fever is there in more than 90% of patients with infective endocarditis.
Okay.
Okay. So,
yes, ma'am. Normal.
And peripheral signs are seen in very few patients, around 5 to 10% or maximum 20%. That too in chronic, like long-standing history, 2 months history of fever, they may develop. Whereas in acute presentation, they may not have any peripheral signs. So it may not add much. Okay.
Yes, ma'am.
Fine. So there is evidence of
Cardiomegaly is there, ma'am.
Yeah, apical impulse is shifted out and down both. But more important is how much area it occupies. Yeah, you were telling something about normal apical impulse. Can you tell for the benefit of?
Normal apical impulse, it occupies less than 2.5 centimeter square or one intercostal space. The location is in the left mid-clavicular line, half an inch medial to the mid-clavicular line. It has a medial systolic
Which
retraction.
intercostal space? Which intercostal space?
Left, ma'am. Left fifth intercostal space.
Yeah, in children it can be fourth also. Fourth or fifth intercostal space. Either 10 centimeters from the within 10 centimeters from the mid sternal line or midline, or 1 centimeter from the
Mid-clavicular.
mid-clavicular. When it occupies less than
2.5
2.5 centimeter square and 1 intercostal space, and
has a medial retraction during systole.
no, before that, what is how long? How
It
much
lasts
of systole?
it lasts less than 2/3 of the systole, ma'am.
Not 2/3. You should say less than one. Yeah,
One
1/3, or maximum 1/5, 1/2, 50%. Okay.
50%.
Yeah. It's a gentle tap occupying less than half of systole.
Yes,
Okay,
ma'am.
and no palpable events. That is a normal apical impulse. So, if according to you it is 6th intercostal space and 2 centimeter lateral to midclavicular line, it is shifted out. This shifting can be because of chest abnormalities
Yes, ma'am.
also, or it can be due to other lung pathology also. So, more important to detect dilatation of the LV is how much area it occupies. That is also
Yes, ma'am.
okay. Anyway, so this is one point to say that LV is dilated. Okay. Is it LV apical impulse or RV? How do you differentiate?
We ask the patient to lie supine and look at the point where there is a retraction that is seen, ma'am.
Yeah, if it is LV apical impulse, it is well localized and
Medial retraction is seen.
supposed to see the medial retraction. We'll discuss it later. If it is RV apical impulse, it is diffuse. You cannot localize, and there should be left parasternal heave or left parasternal impulse, which continues up to the apex. There is nothing in between. Okay, there is no medial retraction, and there should be RV impulse, parasternal, left parasternal pulsation or heave, which continues up to the apex.
Okay.
Okay. If the apical impulse occupies 2 intercostal space or more than 2.5, you don't call it as diffuse, you say it occupies. If it is LV apical impulse, you can still localize.
Yes, ma'am.
Okay. Diffuse means you cannot localize.
Yes, ma'am.
Then it is RV. And there is no medial retraction. If at all, you may see the lateral retraction. So that is how you differentiate RV from LV apical impulse. Okay. You said hyperdynamic. So hyperdynamic, see, there are only 2 abnormalities of the apical impulse. Once you diagnose it as LV.
Yes,
What are those 2?
heaving and hyperdynamic, ma'am.
Correct. One is hyperdynamic, which occurs in
Systole. In volume overload condition.
volume overloaded, AR, MR, BSC, PDA. Okay, or any hyperdynamic circulation. Here, how do you differentiate hyperdynamic from heaving?
Heaving, yes, ma'am. Heaving, it is localized to one
First, you
single.
tell hyperdynamic, then it is easier.
Yes, ma'am. Okay. Hyperdynamic, it may extend more than 1 intercostal space.
That can happen in both.
Both. Okay, ma'am.
So here,
It is forceful
amplitude
and
is
well
increased.
sustained, ma'am.
Okay, amplitude is increased. It pushes your finger, it lifts your finger,
But it is ill
but
sustained.
the duration is less than half of systole.
Yes, ma'am.
Okay. The amplitude is increased, not the duration.
Duration.
Okay.
Yes, ma'am.
Whereas heaving apical impulse or sustained apical impulse, the duration is increased. Amplitude also may be increased, and the duration is increased more than half of systole, 2/3 of systole, or so.
Yes, ma'am.
So that you classically get in LVOT obstructions, aortic stenosis, hypertrophic cardiomyopathy, hypertension, and also LV dysfunction.
Okay.
Okay. You
Okay.
can get a sustained apical impulse in LV dysfunction. Even in AR, MR, when they develop LV dysfunction, you can get a sustained apical impulse. You don't have to worry that it is not fitting into your diagnosis. You have to worry about the patient because sustained apical impulse in AR or MR indicates that there is LV dysfunction.
LV dysfunction. Yes, ma'am.
Okay.
Yes, ma'am.
Okay. Then you should have mentioned about the parasternal heave. You missed it. So next point is parasternal heave is there or not. Epigastric impulse is there. Okay. Epigastric pulsations are there. What are the causes of epigastric pulsations?
One is it can be because of AR. One is because of TR, or one it can be because of tricuspid stenosis.
No. I am not asking.
No. RV enlargement, or it can be because of aortic regurgitation or tricuspid regurgitation.
Somebody has correctly put it. Hepatic pulsation or aortic pulsation or RV pulsation. So RV pulsation could be because of RV hypertrophy or RV volume overload. So you put your finger in the epigastric region towards the left shoulder. It will ask the patient to take a deep breath. It will come and push your thumb. Aortic pulsation, what is the common cause for aortic pulsation?
Aorta aneurysm.
Don't tell that first. Normal thin individuals, you can feel the aorta normally also. Okay. Do you expect in this patient aortic pulsation?
We expect in this patient to have.
Yeah. Yeah, itself can cause. Okay. So aortic aneurysm should be the last answer.
Yes.
Any hyperdynamic circulation, RSO, you can get a aortic pulsation. Third is hepatic pulsation. Where do you get hepatic pulsations?
Tricuspid regurgitation, or
Classically, systolic pulsation of the liver is felt in severe tricuspid regurgitation. Yes, Rosenbach sign severe aortic regurgitation. Yeah, more often we say, but I never felt it. And rarely you may feel pre-systolic pulsations because of severe tricuspid stenosis. Rare. Oh. Go ahead. So that is important. Pick up the parasternal heave. What does it suggest if there is parasternal heave?
It suggests right ventricular enlargement.
See, again, here also you can differentiate whether it is RV volume overload or pressure overload. If it is RV volume overload, you just feel the pulsation. Okay. If it is pressure overload, it lifts for more than 50% of the systole. That is heave. Okay. Heave is there, it indicates RV pressure overload. Pulmonary hypertension, pulmonary stenosis. Here we expect a pulmonary hypertension because patient has gone into right-sided failure. Usually they will have some amount of pulmonary hypertension before they develop right heart failure. So you should look for parasternal heave and epigastric pulsations of RV origin. Both indicate that there is increased pressure in the right ventricle.
Yes.
Oh.
Diastolic thrill was felt in the left third intercostal space.
Okay. So no other pulsations, no
thrill.
thrill.
Pulsations were.
The other thing it should see, even if it is not there, you have to mention one is there is no parasternal heave, there is no epigastric pulsation. That you have written, but you have to emphasize that. Then any PA pulsations, pulmonary artery pulsations, which may be felt in the left second space, again indicates pulmonary hypertension. Okay. Or a palpable second sound. You don't have to tell palpable P2, you have to say palpable second sound, because you have to decide whether it's A2 or P2 by the company it keeps. Here in valvular heart disease, it's always P2, but sometimes in congenital heart disease, it can be A2. So you have to say it is palpable. There is no palpable second sound. Okay, go ahead.
Percussion, the upper border of liver dullness was noted at the left fifth intercostal space. The left heart, right fifth intercostal space. Left heart border corresponds to apex, and the right heart border was substernal in location.
I'm glad you percussed, because percussion is almost deleted in most of the clinical books, I think. But here, what we are interested is one is left second space. If there is a dullness in the left second space, it indicates pulmonary artery dilatation secondary to pulmonary hypertension. Apex usually corresponds. That will not help us much. Sometimes right heart border percussion may indicate right atrial enlargement. And in congenital heart disease, percussion of the liver and the stomach dullness, liver dullness in the stomach resonance for situs. Okay.
Yes.
Go ahead.
Coming to the auscultation, in the apex, the S1 was normal, S2 was heard. LV S3 was heard on auscultation. There was no murmurs that were appreciated on the apex. In the coming to the
1 second. In cardiology, we don't go by areas.
okay,
Because it's okay. You can go ahead. Go with you because many times AR murmurs can be heard in the apex. So
yes,
like that. So other thing is when you comment about the heart sound,
yes, ma'am.
S1 is commented in the apex and the tricuspid area. Okay.
Yes, ma'am.
S2 you comment in the pulmonary area. A2 in the aortic area. Okay. Because P2 is heard only in pulmonary area. Normal P2 is heard only in pulmonary area. So you can say apex S1 is normal.
Okay.
Okay. This S3 is LV S3, is it?
Yes, ma'am.
It should specify.
Yes, ma'am.
Anyway, apex it is LV. It has to be LV S3. Okay, fine.
Okay. So in apex, LV S3 was heard. There is no murmurs. Coming to lower left sternal border, S1 was normal. There's no added sounds or murmurs heard in the lower left sternal border. Left third intercostal.
What murmur you look for in this patient?
Tricuspid regurgitation murmur we'll have to look for because you're thinking pulmonary hypertension may be a possibility because of.
When patient goes into right heart failure, in a patient with left-sided lesion, usually they'll have pulmonary hypertension and tricuspid regurgitation. So anyway, your JVP also you said normal. I expect a elevated JVP with a prominent V wave if there is TR.
Yes, ma'am. I'll see it again today, ma'am.
Yeah. And if you look for a murmur of TR, how do you look for a murmur of TR in the tricuspid area?
Yes, the patient should be in the supine posture with the diaphragm of the stethoscope. Usually the TR murmur is a pansystolic murmur, which increases on deep breath held in deep inspiration or passive.
No. That is what I see.
Passive
yeah, one is inspiration. It is not held inspiration. It is during the act of inspiration. You ask the patient to take a breath slowly. You should look for increase during the first few beats. Once the patient holds the breath, it will not increase. Okay? It is during the act of inspiration. First few beats when patient takes the breath, not at the end of inspiration because venous return increases. Okay. Other is passive leg raising. Why did you say passive? Will you ask the patient to lift the leg? What happens if patient lifts the leg?
I mean, contract abdominal muscles and all intrathoracic pressure will.
No, there will be Valsalva. Valsalva will decrease the venous return. Yes. Both your hepatocellular reflex and during active leg raising, there can be Valsalva. So you ask the patient to breathe normally and do these things. Okay, otherwise Valsalva will decrease the venous return.
Yes. The left third intercostal space, there was a grade 4 early diastolic murmur heard that was best heard with the bell of the stethoscope. The patient leaning forward and breath held in expiration.
This grade 4 is by 6 or 4?
By 4, ma'am. 4 by 4.
Usually they object diastolic murmurs.
Okay, only just EDM if we mention sufficient, ma'am.
So what is important here? You said left third intercostal space, grade 4 and early diastolic murmur, best heard with bell of stethoscope, leaning forward. See, when there is already grade 4 murmur, why do you want to put patient leaning forward, held in expiration? Already it is so loud, no?
Yes,
it cannot become grade 5, right? Already thrill is there. So that maneuvers you do only when there's a faint murmur. To bring a faint murmur, you put the patient, usually it's a high-pitched murmur, soft murmur. So then you ask the patient to bend forward and breath held in expiration. But already loud murmur, there is no need to do.
Not required. Okay, ma'am.
But what is more important than your loudness is, how do you assess severity of AR? Length of the murmur. You should tell the length. How long is the murmur? Is it
more
occupying
50% of
more than 50% of diastole? If it occupies, it indicates severe aortic regurgitation. If it occupies less than half of diastole, it indicates
moderate.
Yes, moderate. But there are exceptions when there is LV dysfunction or acute AR, it may become short. Okay, even acute AR, you may not even hear the murmur. So generally in chronic AR, you assess the severity by assessing the length of the murmur. Okay, that you should mention.
Yes.
Okay.
Coming to the right upper sternal area, this one was heard.
It's okay. You can use the same pulmonary area. You can use, no problem. You tell, no problem. Mitral, you go according to your whatever you are supposed to.
Okay.
So pulmonary area again, you don't have to mention about S1. Okay. S1 is mentioned in apex and tricuspid area. Okay.
Pulmonary area was normal. There is no
I want to hear more about S2 because S2 is 3 things you have to tell in pulmonary area. Whether it is split.
Yes, ma'am.
If it is split, what is the respiratory variation?
Okay.
Second, third, what is the intensity of each component?
Okay.
How normally what is the second sound in pulmonary area? Can you describe a second sound in pulmonary area? Normal second sound.
Ma'am, in second sound in normally in pulmonary area there will be a inspiratory split in the second sound, ma'am.
Correct.
With the P2 component being louder, the P2 will be heard best, ma'am.
No, during inspiration, you hear 2 sounds. A2 first,
A2
then
and
P2.
A2 followed P2.
A2 followed by P2.
Yes, ma'am.
During expiration, you hear a single second sound
yes. Because there is increased venous return in the during inspiration and pulmonary hangout interval increases during inspiration.
Yeah, the P2 moves away from A2 during inspiration. During expiration, the distance between the 2 sounds is less than 30 milliseconds. Okay, so our ear can appreciate 2 sounds as 2 sounds only when the distance between 2 sounds is more than 30 milliseconds.
Okay.
If it is less than that, we think it is single sound. So during expiration, the distance between A2 and P2 is less than 30 milliseconds. So it is heard as a single sound. Whereas during inspiration, the distance, the P2 moves away from A2. A2 comes earlier. So the distance is more than 40 to 50 milliseconds. That is why you can appreciate 2 sounds. Okay. Second point. Third, you have to say intensity of A2 and the P2.
Yes.
Normally also in pulmonary area, A2 is louder than the P2. If the P2 becomes equal to A2, there is already mild pH. If the P2 is louder than A2, then it is moderate pH. If the P2 is loud, banging and heard in other areas also, it is severe pH. So this is one way of assessing the severity of pulmonary hypertension. Okay. Even in pulmonary area, though you say it is pulmonary area, A2 is louder than the P2.
Okay.
Okay, so these are the 3 things you have to explain when you are describing a second sound.
Okay.
Whether it is split or not. If it is split, whether it is normal split.
Okay.
And intensity of each component.
Okay.
So when do you say it's wide split? Split is heard both during
in inspiration and expiration.
And expiration, but it is varying. Inspiration is more, expiration is less. But you can hear the split during throat respiratory cycle. When do you say it's fixed?
When there is no change, it is wide.
There is no change
in between inspiration and expiration.
And also you make the patient sit, stand, it doesn't vary.
Okay.
Okay, sometimes wide split, it becomes single on standing. In children, you can get a wide split. It may appear fixed, but when you make the child sit or stand, it becomes narrow. So that is wide fixed split. Then what is paradoxical split?
P2 will come before A2, ma'am.
You cannot make out clinically whether it's A2 or P2. So you hear the split during expiration and single sound during inspiration.
Okay.
So during expiration, you are right. A2 comes after the P2. But we cannot make out unless you record, you cannot make out. So clinically, we say paradoxic split or reverse split when you hear the split during expiration and single sound during inspiration. Okay. So here you should have looked for the loud P2.
P2. Yes, ma'am.
Fine, go ahead.
In the aortic area, there was a crescendo, decrescendo, mid-systolic murmur of grade 3/6 in intensity, which was heard on the diaphragm of the stethoscope with the patient leaning forward and breath held in expiration and was radiating to the carotids.
So I thought you're okay. See, you should go systematically if you're going by area. First apex, tricuspid area, left sternal border, then last you should go to the right second space or aortic area. Okay.
Yes.
So here you brought that before the pulmonary.
The diastolic, in left third intercostal space, the diastolic murmur was heard best.
That you told. Then you should go to pulmonary area, then aortic area, if you're going by area. Otherwise, what we do is we say S1 normal, S2 something like that, no added sounds, or S3 is there, then you go to murmurs.
Murmurs, okay.
Cardiology, we don't follow areas, but you still follow. But if you're following, you go in the order.
Yes,
Mitral, tricuspid, left sternal border, pulmonary area, and then aortic.
So no
Okay,
other
go ahead.
no peripheral signs of AR was found, ma'am.
Why are you telling that now? What happened? This murmur you explain, no? Crescendo, decrescendo, something you are saying. Systolic murmur.
Yes, ma'am. That is suggestive of aortic stenosis, ma'am.
No, I will tell it is a flow murmur. Increased flow across the aortic valve due to air. What is your objection?
S2 is soft, ma'am.
Hey, don't tell again S2 soft. S2 cannot be soft unless you say it is single.
Single. S2 is single.
No, yes, I told you, you have to comment about A2 and P2. S2 cannot be soft. S2 has two components. It's not like S1.
Yes, ma'am.
S2 should have two components and you should describe
A2
both.
and, okay.
Yes. So S2 cannot be soft unless you say S2 is single.
Okay. S2 was
Clear or you have still have doubt?
Got it, ma'am. Got it.
No.
S2 was single in this patient, ma'am.
You said your S2 split single. S2 cannot be split in single, no?
No, in pulmonary area, I heard this one, ma'am. It was single. That split was not there. The S2 split is single, is what I mentioned.
But you have written S2 split single. What is that?
There is
anyway,
no.
You can change this. You have understood. Hopefully, you understood. Pulmonary area, you have to say S2 is either single or S2 is narrow split. S2 is normally split. Once you say it is split, you have to talk about A2 muffled or A2 loud or A2 normal, P2 muffled or P2 loud or P2 normal. So both components you have to explain in pulmonary area. If you are hearing only one component, then you have to decide whether it is A2, whether it is P2, or it is combined A2, P2. Okay? Anyway, it is difficult, but you should understand the basics.
Okay.
In aortic area, you can say it is A2.
Okay.
Okay. Only in pulmonary area, you have to comment about both the components.
Okay.
You cannot say S2 split and single. That is wrong. Okay. You say S2
single. S2 is single, man.
Okay. So why S2 is single? Is it because of A2, P2, or combined A2, P2?
I was not sure how to.
Yeah, it's okay. So that again you have to decide by the company it gives. It could be because of delayed A2. Okay. In AS, what happens? A2 is delayed, so it will merge with the P2. Or A2 is muffled, you are hearing the P2. Okay. So single second sound in aortic valve disease could be because one, A2 is muffled because of calcified aortical or whatever reason.
Yes,
so you are hearing only P2.
Yes,
or A2 is delayed and it overlaps with the P2. You are not able to, the distance between the two sounds is less than 30 milliseconds. So it is not heard. That is the second cause for single second sound. Third, now the A2 goes beyond P2 and the murmur covers the P2. So you're not able to hear the P2. Okay? You're hearing the A2. So these are the three causes of single second sound in aortic valve disease.
Okay.
Okay. So this murmur you have to decide whether it's a functional murmur because of increased flow across the aortic valve, or there is an organic aortic stenosis. So that is based on
The blood pressure that was there.
no. Murmur itself can give you a clue. If it is a long murmur,
Okay.
see, how do you assess severity of AS by murmur? Murmur is long, late peaking, and loud. Okay, if you get a harsh murmur, which is long, going all the way up to the second sound, A2, and it peaks later in the systole. Suppose you have a short murmur, which stops before the A2 and peaks in the early part of systole, it is mild to moderate, or it could be functional because of increased flow. If you have a long, harsh murmur going up to A2, then it is organic AS. That's how you decide based on the murmur. Okay. There are other reasons. If there is a decapitation of systolic blood pressure, that favors AS. Okay. So other systems normal, you said?
Systems are normal, ma'am.
See, peripheral signs of AR you can tell in the general examination. You don't have to come up to here.
Okay.
Somebody is asking whether there are other signs. So once you find a wide pulse pressure, you should mention all the peripheral signs, whether it's there or not.
Okay.
Okay. Other systems?
The
You told
systems are
before.
normal.
Okay. In cardiology, we tell later. That is why I was looking for it. You told already. Okay. Fine. What's your diagnosis?
Valvular heart disease in the form of severe, I'm thinking moderate aortic regurgitation with mild aortic.
Why you're saying moderate? Anyway, you tell complete, then we discuss.
Moderate.
Okay, yeah, it's becoming 8 o'clock. Is it okay? Another 10 minutes you can discuss?
No problem, ma'am.
No problem. Okay, go ahead.
Moderate aortic regurgitation with mild aortic stenosis in sinus rhythm in congestive cardiac failure without evidence of infective endocarditis or embolic phenomenon. In NYHA class 3 with medications currently. Etiology being probably a bicuspid aortic valve or a rheumatic heart disease.
Okay. So how do you say it is severe AR? You are written severe AR. Why are you saying moderate AR?
After when you're saying the discussion,
It's okay. Severe AR. The patient has gone into failure. No, moderate AR will not cause
yes, ma'am.
Failure. So if AR is the cause for her failure, it has to be severe.
Yes,
okay. Now you tell me how will you assess severity of AR quickly?
Yes, ma'am. One on the examination, one is the wide pulse pressure based on the Hill sign, ma'am.
Very good. So Hill sign is one more than 60. Second, Bispherians pulse.
Bispherians pulse, ma'am.
Then wide pulse pressure with low diastolic pressure. See, what is the requirement for a collapsing pulse? One is wide pulse pressure, other is low diastolic pressure. Wide pulse pressure per se will not cause collapsing pulse.
Yes,
see, you may have a blood pressure of 200 by 100. Yes, there you get a high volume pulse, but you don't get a collapsing pulse. Collapsing pulse should have a low diastolic pressure also. Here, her diastolic pressure is around 70. So that is not very helpful to you. So you should have a diastolic pressure something like below 50. Then it indicates significant aortic regurgitation.
Yes,
but as we said, LV dysfunction, the diastolic pressure may go up, or associated other valvular lesions, it may mask the findings. So low diastolic pressure and other peripheral signs of aortic regurgitation will tell you that there is a severe aortic regurgitation. Suppose this patient has a BP of 150 by 30.
Yes, ma'am. Severe it becomes.
Correct. So we think of a severe aortic regurgitation. One more thing, when you record the blood pressure, what do you take? Whether it is muffling or disappearance for output sounds?
If there is we should take phase 4 of the Korotko sounds.
Yeah, in these patients with wide pulse pressure, low
persistent sounds,
you can take the disappearance. If the difference between the muffling and the disappearance is more than 10 millimeter mercury, you can mention both.
Okay.
Sometimes it can be 0. Muffling may be at 40. Disappearance at, it is still heard because Even if you release, you may hear the sounds over the brachial artery. So then you write both. So diastolic pressure, normally it cannot go below 30.
Okay.
It corresponds to the muffling here. Usually you take disappearance, here you take muffling, but you can write both. Okay. So one is peripherally, these are the things: white pulse pressure, then kill sign, variance, and signs of free aortic leak. Okay. Then coming to the
examination, Manus, the chronicity will be based on down and out apical impulse, ma'am.
Okay. So we are talking about chronic only. Dilated, hyperdynamic,
Dynamic apical
left
impulse.
ventricle, right? Then length of the murmur.
Length of the murmur, ma'am.
Which we discussed. Third, any other murmur you looked for in the apex in this patient?
MDM, presence of MDM again will make it.
Austin Flint murmur. Austin Flint murmur in the apex.
Yes, ma'am.
So, S3, does it help you to assess severity here?
S3 indicates failure more than severity. Ma'am.
Yeah, in AR it may indicate LV dysfunction, whereas in MR, S3 indicates severity
of the lesion. Yes,
okay. So, you not heard Austin Flint murmur, but that helps if it is there. Okay. So here we have a dilated hyperdynamic LV and a long diastolic murmur. That is enough to tell it is severe aortic regurgitation. Patient is in failure, so other findings may be masked because of LV dysfunction. Okay. Then there is some evidence of aortic stenosis also. You said grade 3 murmur. Was it a long murmur?
Grade 3, ma'am. Long, ma'am.
Long murmur?
Long, ma'am.
Long, harsh murmur indicates.
And this one was like the second heart sound was single, ma'am.
That is okay. Second heart sound will not decide the severity.
Okay.
You can get a paradoxic split also in AR because A2 can be delayed because of increased aortic dilatation. Do you think it is AR is valvular pathology or root pathology? How do you differentiate?
We'll see based on where is the murmur heard best, ma'am. Whether it is on the right side or the left side. If it is in the left third intercostal space, it's normally the valvular. If it is in the right side, it's probably the root involved.
Correct. If the murmur is better heard on the right side, second or third intercostal space, it is root dilatation. And other thing is second sound. If the A2 is loud, it goes in favor of root dilatation. The A2 is muffled, it goes in favor of valvular. Third is dullness. If you get a dullness to the right of the sternum, on the right second intercostal space, that goes in favor of root pathology. Anyway, if you bring in aortic stenosis, it is likely to be valvular. Right?
Yes, ma'am.
You cannot get in root dilatation.
Yes, ma'am.
Organic AS. You may get a functional murmur, but once you say it's organic aortic stenosis, it has to be valve pathology. But you said bicuspid aortic valve. How did you diagnose bicuspid aortic valve?
I'm not diagnosed, ma'am. Like probably because if we take aortic valve disease, usually the etiology would be degenerative aortic valve disease. Usually it is beyond 60 or 70 years of age. Beyond 60 years of age. Because
what finding would have helped you to say it is bicuspid aortic valve?
Bicuspid aortic valve, the click may be heard, ma'am.
Yeah, if there is an ejection click, that would have helped you to localize it to the valve. Okay. So anyway, it is both AS and AR. It could be still rheumatic, but how will you rule out rheumatic here? Or diagnose rheumatic here?
Unusual that like only aortic valve involvement is
isolated aortic valve is hardly seen in 4 to 5%. Okay, so that can be decided only by echo. If there is an involvement of the mitral valve, some thickening, involvement of mitral valve, then you can say it is aortic valve. If the mitral valve is normal, then you cannot diagnose rheumatic heart disease. Okay. Though we say isolated aortic valve disease, echocardiographically there should be involvement of the mitral valve.
Okay.
So bicuspid aortic valve is more common in males or females?
More common in
It's more common in males.
males, sorry.
When do they get AR? AR dominant. Usually the natural history of bicuspid aortic valve is progressive thickening, fibrosis, calcification of the leaflets causing aortic stenosis.
Yes, ma'am.
Usually in the 5th decade.
Yes, ma'am.
But they can develop aortic regurgitation. So 15% of them may develop isolated AR.
Okay.
Majority develop AS, but sometimes combined AS-AR. When do they develop AR? It may be because of endocarditis. Because what is the incidence of bicuspid aortic valve in the population?
Not sure.
The most common congenital heart disease, 1 to 2%. 1 to 2% of the
Population.
normal population can have bicuspid aortic valve. So the natural history is progressive AS, but they can develop AR because of infective endocarditis
Yes.
or prolapse of one of the leaflets or aortic root dilatation, because patients with bicuspid aortic valve are prone for aortopathy like Marfan syndrome.
Okay.
So they can develop aortic root dilatation in AR, which is less common than Marfan's.
Okay.
So sometimes even the leaflets can retract and cause AR, but usually that occurs in younger age, whereas AS occurs in older age group. Okay, you have anything else?
No.
Stop at this.
I didn't add it here now.
It's okay. So what was the anything else you want to add? ECG, X-ray, or we'll stop here?
I don't have it currently, ma'am.
But you know the diagnosis?
Oh, yes, ma'am.
Okay, anyway, it's okay. What do you expect in the ECG?
In the ECG, we expect volume left ventricular enlargement with left atrial enlargement.
Left ventricular
hypertrophy.
LVH, you will not say enlargement on a ECG, right?
LVH.
You say LVH with volume
overload. Yes, ma'am.
Yeah, LVH criteria you all know, I'm sure. But you have to differentiate volume overload or pressure overload. How do you differentiate volume and pressure?
Usually pressure overload, there will be T-wave inversions that will be associated with the LVH.
No, if it is volume overload, you get deep Q waves in V5, V6.
Deep Q wave, T-wave
and
inversion.
ST elevation with concavity upwards in V5, V6. And upright T waves.
Yes, ma'am.
That is volume overload. Whereas in pressure overload, opposite occurs. Q disappears. There will be ST depression with convexity upwards and asymmetric P inversion.
Yes,
okay. So here your diagnosis is little incomplete because you have to say whether there is pulmonary hypertension or not.
Okay.
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 I'm sure it will be there. Okay, any doubts? Anyway, you have to confirm the diagnosis with ECG, X-ray and echo. After that only we'll plan management.
Yes, ma'am.
Okay. Any doubts?
Next time I'll add everything.
Okay, sure. Yeah, if it is there, it will be good. No, you have to know ECG, X-ray at least.
Yes, ma'am.
Echo, you can just know the diagnosis, but ECG, X-ray, I think you should know.
Yes, ma'am.
So, any doubts or shall we stop here? Or?
It's clear, ma'am.
Ma'am, management, ma'am.
Management, because I thought he has no diagnosis. Anyway, you know the diagnosis, you tell, we'll discuss the management. It was severe AR?
It was severe AR, ma'am. With moderate AS was what was mentioned.
Moderate AS, severe AR. Okay.
Mitral valve was normal, ma'am. EF was 56%.
Oh.
Dilated, all four chambers were dilated.
Okay. What was the PA pressure?
PA pressure was 46, they had mentioned, ma'am.
There must be some pH. TR was there?
TR, moderate TR, they had mentioned.
Okay. Okay. So surgeon is here. So how do you manage now? EF, any idea about the ejection fraction?
56%, ma'am.
Oh, 56 is reduced. So what is the pathology? Aortic valve pathology?
Ma'am, they didn't mention.
Aortic valve or rheumatic?
They didn't mention that, ma'am. That was not mentioned.
Not
Like rheumatic versus bicuspid.
Yeah,
Bicuspid
patient-
aortic valve, they didn't mention that. That
Yeah,
was
patient is in failure. You have to first treat the failure, then definitely needs aortic valve replacement.
yes.
What are the indications for aortic valve replacement? Yeah.
Severe symptomatic AR.
So first you have to ascertain that it is severe AR. So if they have symptom, that is not palpitation. If they have dyspnea,
Dyspnea, failure
class
symptom.
2 or more, it is an indication for surgery. If patient is asymptomatic, then what will you do? You look at the LV
Maybe
dimension and LV ejection fraction. So LV dimension, cutoff value is 50 millimeter
okay.
and ejection fraction is 50%.
Okay.
So that is indication for surgery in asymptomatic AR. Suppose patient is asymptomatic, LV is not dilated, LV function is normal, then you follow up.
Okay. Sure.
So that's it.
Dear members, do you have any doubts? It's a good opportunity to learn from the legend. So any doubts, however silly you feel, please ask directly and clarify with madam. She is the authority in cardiology, so she will make any doubts clear for you. Please ask. Feel free to ask any doubts. Make the best use of these opportunities, my dear friends. Madam, you made the concepts very clear, ma'am. So many, like most of us were doing like these clinical examination and many of things very mechanically without knowing real the concept behind them. Now the many this may it be examination of JVP or like a pulse examination. You told the concepts behind them very clearly and made it very scientific and logical, ma'am. This is why
Okay.
we love cardiology. It's like mathematics, so everything is logical and scientific.
Okay. Thank you.
Thank you so much. And
Anyway, one
Vijay,
class
you
we
presented
cannot
really
take.
very well. You presented really well.
Okay.
Yes, ma'am. No, we'll have subsequent classes, ma'am. One small topic, like you told, one JVP is a separate class, one on pulse we may have.
Okay, I have.
If you whenever at your convenience, ma'am.
Okay.
Yes, ma'am.
At your convenience, we'll have, ma'am.
Yeah. No, actually, I used to
Balaji, you
take.
presented really well. We learned a lot of things through you.
Okay, it's good presentation, but keep improving. Mr.
Yes, ma'am.
Thank you.
And I should worth
I
mentioning about some of our members also, like Ravish and they and some other Arjit Singh. They all did very well in chat section. They answered really well. Keep up the spirit and keep answering like that. Thank you so much for everyone for participating in this special session of cardiology by Prabhavati madam. Once again, we all, on the behalf of our entire White Army members, we wholeheartedly thank and seek your blessings, madam. Prabhavati ma'am, please bless us and all the members.
always.
Thank you so
Always.
much for being
Thank
with
you
us.
so much. Thank you. Thanks for the arranging.
Thank you so much, ma'am.
Yeah.
Thanks, Vijay. You presented well.
Yes, ma'am. We'll
Yeah.
try to do it better next time, ma'am.
Yes. Yeah.
With your guidance.
JVP, you should be more confident. You should.
Yes, ma'am.
Anyway, now COVID time, it's difficult to examine in detail. I can understand. So,
Yes, ma'am.
okay.
Thank you so
Thank
much.
you. Best
Thank you.
wishes.
Thank you.
Thank you, madam.
Thank you.
Tapan, let's end the session.